You're listening to Who Said, a cardiology board review series. No fluff, just facts.
This episode is about a pulmonary artery catheter or Swan catheter, as well as right heart catheterization. We will go over indications and contraindications. We will focus on venous oximetry, causes of high and low SvO2, as well as the oxygen content and delivery equation. We'll then go through pressure measurements as well as resistance measurements in each of the various chambers. We'll then talk about a few extra measurements such as the PAPi and the CPO. Then we'll end with a section on the LVEDP and what you should know about it. Let's start with the indications. The tide has turned against the PA catheter in clinical studies that have come out in the last decade or two. Compared to the 2013 heart failure guidelines, the role of the PA catheter is watered down and more ambiguous in the 2022 AHA-ACC guideline for management of heart failure, although it still allows for its use. In patients with heart failure, routine use of invasive hemodynamic monitoring is not recommended. That's class 3, no benefit. In selected patients with heart failure with persistent or worsening symptoms, signs, diagnostic parameters, and in whom hemodynamics are uncertain, invasive hemodynamic monitoring can be useful to guide management. Class 2A. The 2022 heart failure guidelines argue that there is no role for routine or periodic invasive hemodynamic measurements in the management of heart failure because most drugs used to treat heart failure are prescribed on the basis of their ability to improve symptoms or survival, rather than their effect on hemodynamic variables. The initial and target doses of these drugs are generally selected on the basis of controlled trial experience rather than changes produced in cardiac output or pulmonary capillary wedge pressure. They cite the ESCAPE trial, which was the evaluation study of congestive heart failure and pulmonary artery catheterization effectiveness, which found that routine use of PA catheter monitoring for patients with heart failure did not provide benefit. However, they acknowledge that invasive hemodynamic evaluation or monitoring can be useful to guide management in carefully selected patients with acute heart failure who have persistent symptoms despite treatment. This includes patients whose fluid status, perfusion, or systemic or pulmonary vascular resistance is uncertain, whose systolic blood pressure remains low or is associated with symptoms despite initial treatment, or whose renal function is worsening with therapy, or who require parenchymal vasoactive agents. Moving from indications to contraindications. Contraindications to placing a PA catheter include presence of a right heart mass, presence of a mechanical tricuspid or pulmonic valve, tricuspid valve endocarditis, tricuspid stenosis, or pulmonic stenosis, because you won't be able to get through with the catheter and the balloon. The times when bedside placement of a pulmonary catheter should be deferred to the cath lab include presence of left bundle branch block because these individuals are at risk of developing transient right bundle branch block, thus causing complete heart block, ICD or pacemaker placement within the last 6 months, so you want to make sure you're not dislodging the ICD or pacemaker, prosthetic tricuspid valve or pulmonary valve, temporary pacing wire in place, severe tricuspid regurgitation, thus making your balloon float backwards and you'll want to be able to see it on fluoroscopy. Pulmonary hypertension with severely elevated PA pressures more than 70 millimeters of mercury, increasing the risk of PA balloon rupture. Femoral access required, or RA enlargement or RV dilation. After placing the pulmonary artery catheter, you should record the depth of the PA catheter after placement in terms of centimeters at the introducer, the volume of air needed to wedge, and the relationship of the PA diastolic pressure and wedge pressure, whether they correlate. And this will come in relevant shortly. Now let's switch gears and talk about venous oximetry. Global impairment in oxygen delivery or use can be monitored using the SCVO2 or the SVO2. The SCVO2 is the central venous oxygen saturation, whereas the SVO2 is the mixed venous oxygen saturation. The SCVO2 is measured at the SVC-RA junction with the central venous line, rather than a Swan catheter. The normal SCVO2 is 70 to 75%, reflecting a 25 to 30% extraction. In contrast, the SVO2, which is the mixed venous oxygen saturation, is measured at the pulmonary artery with a Swan-Ganz catheter. Normal SVO2 is 65 to 70%. It's 5% lower than the SCVO2 because it contains blood from both the SVC and the IVC. Since the SVO2 and SCVO2 are affected by the same four factors, CO, hemoglobin, saturation of oxygen, and O2 consumption, the SVO2 and SCVO2 tend to trend together clinically as long as there is no congenital disease. Let's understand the oxygen content equation. This equation calculates the total amount of oxygen carried in arterial blood, which is milliliters of oxygen per 100 milliliters of blood, combining both oxygen bound to hemoglobin and the oxygen dissolved in plasma. So the CaO2, oxygen content, equals the SaO2 times hemoglobin times 1.34 plus 0.003 of PaO2. CaO2 is the arterial oxygen content in milliliters of oxygen per 100 milliliter of blood. SaO2 is the arterial oxygen saturation, which is the fraction or percentage, like 98% is 0.98. Hemoglobin is the hemoglobin in grams per deciliter. 1.34 is what they call the Höfner constant, which represents the amount of oxygen that 1 gram of hemoglobin can carry. 1.34 milliliters of oxygen can be carried per gram of hemoglobin. PaO2 is the partial pressure of oxygen in arterial blood in millimeters of mercury. 0.003 is the solubility coefficient for oxygen in plasma. The first part of the equation, which is SaO2 times hemoglobin times 1.34, represents the oxygen bound to the hemoglobin. The second part, the 0.003 times PaO2, accounts for the small amount of oxygen dissolved in plasma, not bound to hemoglobin, which is minimal compared to the oxygen bound to hemoglobin, but still important under certain conditions, for example, during high-flow oxygen therapy or in patients with severe lung disease. Then how about the oxygen delivery equation? The oxygen delivery equation, as opposed to the content equation, determines the total amount of oxygen delivered to tissues per minute by the cardiac output. So it is just a multiplication with cardiac output. DOO2, the oxygen delivery, equals cardiac output times SaO2 times hemoglobin times 1.34. Notice we got rid of the 0.003 coefficient times PaO2 because that can be considered as negligible. So DO2 is oxygen delivery, milliliters of oxygen per minute. CO is the cardiac output in liters per minute, and SaO2, hemoglobin, and 1.34 are the same as above. Oxygen delivery depends on cardiac output and oxygen content. It represents the total volume of oxygen transported to tissues in 1 minute. Cardiac output is a critical variable, and changes in stroke volume, heart rate, or blood volume affect overall oxygen delivery. Oxygen content, CaO2, gives insight into how much oxygen is present in the blood. A drop in hemoglobin concentration, for example in anemia, or in oxygen saturation, for example in hypoxemia, can reduce the oxygen carrying capacity. Oxygen delivery, DO2, is crucial for tissue oxygenation and is influenced by both the oxygen carrying capacity, CaO2, and the cardiac output. Even if oxygen content is normal, a decrease in cardiac output, such as in heart failure or shock, can reduce oxygen delivery and lead to tissue hypoxia. So that's the distinction between those two. Let's go over the causes of low SVO2, meaning less than 65%. There can be low SVO2 due to increased oxygen consumption, such as hypermetabolic states. These include sepsis early phase. I don't want you to associate sepsis in this list though, because most of the time we deal with sepsis in the late phase, and sepsis in the late phase would give you a very high SVO2. So just minimize this one. Hypermetabolic states such as fever, shivering, hyperthermia, pain, agitation, or seizures, or any increased physical activity in general. These can give you low SVO2 due to increased oxygen consumption. You can also get low SVO2 due to decreased oxygen delivery. This can be from low cardiac output, low hemoglobin, or low arterial oxygen saturation. Things that cause low cardiac output leading to low SVO2 are heart failure, cardiogenic shock, and massive pulmonary embolism. Things that can cause low hemoglobin leading to low SVO2 are anemia, hemorrhage, and carboxyhemoglobin. Things that can cause low arterial oxygen saturation, leading to low SvO2, are hypoxemia, which is low PaO2 from conditions such as COPD, ARDS, or pneumonia, or severe chronic pulmonary disease that reduces the efficiency of oxygen exchange. Now let's go to the opposite end and talk about causes of high SvO2, meaning more than 80% of SvO2. You can have high SvO2 due to decreased oxygen consumption. The most common one is sepsis, late-stage sepsis, and middle-stage sepsis. In distributive shock, oxygen is delivered to tissues, but it is not used effectively due to impaired cellular metabolism. That's the mitochondrial dysfunction. Another cause is cyanide poisoning. This prevents tissues from using oxygen by inhibiting cellular respiration, resulting in elevated SvO2 from decreased oxygen consumption. You can also get it from severe hypothyroidism or myxedema coma. Low metabolic rate reduces oxygen consumption. Or general anesthesia. General anesthesia reduces metabolic rate and oxygen consumption. You can get high SvO2 as well from increased oxygen delivery, from high cardiac output, such as cirrhosis or arteriovenous fistula, early stage sepsis, or hyperdynamic circulatory states such as thyrotoxicosis. You can also get high SvO2 from increased oxygen saturation, hyperoxia, if you give high levels of supplemental oxygen that can elevate PaO2 and SvO2. Let's talk about cardiac output and cardiac index. Cardiac output measures the total amount of blood that the heart pumps in a minute, reflecting overall heart function. Cardiac output equals heart rate times stroke volume. Cardiac index adjusts cardiac output for body size. Cardiac index equals cardiac output divided by body surface area. Normal range cardiac output is 4 to 8 liters per minute. Normal range cardiac index is 2.5 to 4.0 liters per minute per meter square. High cardiac output can be seen in conditions such as sepsis, anemia, or hyperthyroidism. Low cardiac output can be seen in conditions such as heart failure, hypovolemia, or cardiogenic shock. There's two main ways to calculate cardiac output, Fick and thermo. When measuring cardiac output via thermodilution, the change in temperature is plotted over time, and cardiac output is inversely related to the area under the thermodilution curve. In low cardiac output states, there's a larger area under the curve due to a longer time required for the temperature curve to return to its baseline. Thermodilution tends to overestimate cardiac output in low output states because the dissipation of the cooler temperature to the surrounding cardiac structures results in a reduction in the total area under the curve. The Fick technique is more accurate than thermodilution in patients with low cardiac output. In patients with severe tricuspid regurgitation, thermodilution-based cardiac output falsely underestimates the cardiac output due to the backflow across the tricuspid valve. In the Fick method, cardiac output is equal to the oxygen consumption divided by the difference in oxygen content between arterial and mixed venous blood. Due to the difficulties in measuring true oxygen consumption in a steady state, many labs use an assumed oxygen consumption based on a patient's age, gender, and body surface area. Now that we've gone over venous oximetry and cardiac output and index, we can go through each of the chambers systematically, starting with the right atrial pressure. Right atrial pressure, or RAP, reflects the pressure in the right atrium and indirectly measures the right ventricular preload and venous return. The normal range is 2 to 5 millimeters of mercury. A high right atrial pressure can indicate right-sided heart failure or tricuspid valve disease, such as tricuspid regurgitation, volume overload, or pericardial disease such as tamponade or constrictive pericarditis, or pulmonary hypertension with right ventricular failure. A low right atrial pressure, on the other hand, usually indicates hypovolemia or decreased venous return. Moving on to right ventricular pressure. This indicates right ventricular function and the pressure required to pump blood into the pulmonary circulation. Normal right ventricular pressure is 15 to 30 over 2 to 8 millimeters of mercury. Elevated right ventricular pressure can indicate pulmonary hypertension, leading to increased RV workload, right ventricular outflow tract obstruction, for example, and pulmonary stenosis, which can be valvular, subvalvular, or supravalvular, or volume overload in the right heart. On the other hand, low right ventricular pressure may indicate hypovolemia or right ventricular dysfunction. Moving on to pulmonary artery pressure. The PAP reflects the pressure in the pulmonary arteries and indicates the resistance and pressure that the right ventricle faces when pumping blood into the lungs. Normal MPAP is 8 to 20 millimeters of mercury. Elevated PAP can be due to pulmonary hypertension, which can be primary or secondary to left heart disease, lung disease, or chronic thromboembolic disease. Please see my dedicated episode on pulmonary hypertension for further details. It also can be left-sided heart failure causing back pressure in the pulmonary circulation, pulmonary embolism, or interstitial disease. Meanwhile, decreased PA pressure can be seen in hypovolemia or low cardiac output states. Moving on to the wedge. The pulmonary capillary wedge pressure is an indirect measure of the left atrial pressure and left ventricular preload. It reflects or approximates the left ventricular end-diastolic pressure in the absence of mitral valve disease or pulmonary venous disease. And we'll come back to this concept at the end of this episode. The normal range for wedge is 6 to 12 millimeters of mercury. A high wedge can indicate left-sided heart failure or mitral valve disease, such as mitral stenosis or regurgitation. It can indicate fluid overload or cardiogenic pulmonary edema, or it can be constrictive pericarditis. Low pulmonary capillary wedge pressure is usually due to hypovolemia or reduced left ventricular filling, for example in restrictive or hypertrophic cardiomyopathy. When wedge is elevated to 13 to 17 millimeters of mercury on chest x-ray, you may see early equalization in the size of the vessels in the apices and bases. It is not until wedge is further elevated to 18 to 20 millimeters of mercury that pulmonary vascular redistribution occurs. When wedge exceeds 20 to 25 millimeters of mercury, interstitial pulmonary edema can be observed on the chest x-ray. In patients with chronic left ventricular failure, higher pulmonary pressures can be accompanied with few clinical and radiologic signs of congestion due to enhanced compensatory lymphatic drainage. Now let's talk about the resistances, SVR and PVR. SVR is a measure of the resistance in the systemic circulation that the left ventricle must overcome to pump blood out into the body. Systemic vascular resistance is obtained by dividing the difference between the mean aortic and right atrial pressures by the systemic cardiac output. So SVR is, in the numerator, SBP minus mean RA pressure, in the denominator, cardiac output. You can either leave it in Wood's units or multiply by 80 to get it to the units of dynes times seconds times centimeters to the power of -5. Normal systemic vascular resistance is 11 to 15 Wood's units, or 900 to 1200 dynes seconds centimeters to the power of -5. High systemic vascular resistance indicates increased afterload and can be from vasoconstriction, which could be due to shock, hypovolemia, or sympathetic nervous system activation, hypertension, or heart failure, especially during acute decompensation, as compensation leads to increased resistance. And of course, vasopressor use is another important one. Low systemic vascular resistance indicates decreased afterload and can be from vasodilation, as in sepsis anaphylaxis, or vasodilator therapy, for example, nitrates or hydralazine, or cirrhosis due to peripheral vasodilation from hormones. How about pulmonary vascular resistance? PVR measures the resistance in the pulmonary circulation that the right ventricle must overcome to pump blood into the lungs. Pulmonary vascular resistance is obtained by dividing the difference between the mean pulmonary artery pressure and the left atrial pressure by the pulmonic cardiac output. So PVR equals MPAP minus wedge all over cardiac output. You can either leave it in Wood's units or multiply the same constant of 80 to get it in the units of dynes, seconds, centimeters to the power of -5. The normal pulmonary vascular resistance is 0.25 to 1.6 Wood's units, or 20 to 130 dynes seconds centimeters to the power of -5. Values exceeding 3 Wood's units, or 240 dynes seconds centimeters to -5, typically suggest pulmonary hypertension. High PV resistance is indicative of pulmonary hypertension and can be seen in PAH, chronic lung disease, pulmonary embolism, or left heart failure. More details on that in the dedicated episode on pulmonary hypertension. Low PVR is generally rare but can occur with vasodilator therapy targeting pulmonary arteries or septic shock. You may or may not have heard of the PAPi, which is the Pulmonary Artery Pressure Index. PAPi is the SPAP minus DPAP all over the CV pressure. So it's the systolic pulmonary artery pressure minus the diastolic pulmonary artery pressure, all divided by the central venous pressure. The PAPi lets you differentiate LV-only shock from biventricular shock. A failing right ventricle will have a low right ventricular stroke volume. Thus, it will have a narrow PA pulse pressure in the numerator and a high central venous pressure in the denominator. Therefore, a bad right ventricle will be reflected as a low PAPi. In LVAD patients, PAPi less than 1.7 to 1.9 predicts risk of RV failure after VAD implantation. In chronic heart failure patients, PAPi less than 1.7 predicts death. In PAH patients, PAPi less than 3.7 predicts worse outcomes. In PAH, the cutoffs are different because PA pulse pressure depends on compliance too, and PAH patients who have stiff PA will have wide PA pulse pressures at any right ventricular stroke volume. A substitute for PAPi is the CVP to wedge ratio. RV dysfunction will cause high CV pressure and low wedge. If CVP exceeds 0.8, that's bad RV function. Another one to know is CPO, cardiac power output. That's the cardiac output times the MAP, all divided by 451. Cardiac power output measures the pumping power of the left ventricle and correlates with end organ perfusion. Cardiac power output less than 0.5 predicts in-hospital mortality. High CPO can help identify patients ready for LVAD weaning trials and/or explantation. How can you use CPO and PAPi for assessing myocardial recovery in a patient that you want to wean an Impella from? If CPO is more than 0.6, so that's a good cardiac power output, then you can wean the Impella if all the following are true. They're off inotropes and pressors, cardiac power output is more than 0.6, there's decreased lactate, and a PAPi is more than 1.0. If the cardiac power output is less than 0.6, so a bad cardiac power output, look at a PAPi. If the PAPi is more than 0.9, that suggests that the RV is still normal. It's only an isolated bad LV. You can escalate the left-sided Impella level, especially if the lactate is not improving at 12 hours. If the PAPi is less than 0.9, suggesting bad RV in addition to bad LV, then consider providing right-sided hemodynamic support using an Impella RP or other equivalent device. That's just one algorithm that is possible. This is by no means the only way to do it, and this is not strictly from the guidelines. So this algorithm for using CPO and PAPi can be operator dependent and center dependent. I just want you to know that. Now, let us go over some important pressure combinations to know. A low systemic vascular resistance with a low mean arterial pressure and a high cardiac output and cardiac index can indicate distributive shock like septic shock or anaphylactic shock. Increased right atrial pressure with normal wedge pressure can suggest right-sided heart failure or pulmonary hypertension. Increased right atrial pressure and increased wedge indicates biventricular failure, or it could also be constricted pericarditis or tamponade. But in that situation, you can look at the X descent and the Y descent, which I will talk about in the episode that follows this one. A high pulmonary vascular resistance with normal wedge indicates precapillary pulmonary hypertension, for example, primary pulmonary hypertension or lung disease. A high pulmonary vascular resistance and high wedge suggests postcapillary pulmonary hypertension, for example, due to left heart failure. There are many more combinations to know, but those are just a few highlights I wanted you to know about. We'll end this episode by talking about LVEDP, left ventricular end-diastolic pressure. What is it and where is it measured? The LV end-diastolic pressure measures the instantaneous pressure in the left ventricle that distends the ventricle just before the contraction that comes after atrial systole. It is measured invasively by left heart catheterization with the catheter dipped in the left ventricle. The LVEDP is not the same as the bottom number in the LV pressure. It is not the same as LV diastolic blood pressure, which is usually slightly lower than the LVEDP. The LVEDP is measured at the onset of left ventricular isovolumetric contraction, coincident with the EKG's R wave after the A wave atrial kick from the left atrium on echo. The LVEDP is normally less than 12 millimeters of mercury. What influences the LVEDP? First, LVEDP can be elevated when the LV experiences excessive diastolic volume overload due to CHF exacerbation, mitral regurgitation or aortic regurgitation, or high volume left to right shunting at or distal to the ventricular septum. Second, LV end-diastolic pressure can be elevated by concentric hypertrophy from hypertension or valvular stenosis, HOCM, restrictive or infiltrative cardiomyopathy, or other left ventricular myocardial diseases that stiffen the chamber, stiffening the pressure volume curve, thus elevating the LV end-diastolic pressure. Is LV end-diastolic pressure the same as the pulmonary artery wedge pressure? Almost, but no. Definitely no. The wedge and LVEDP are sometimes used interchangeably to describe left-sided filling pressures. However, there is a fine distinction. The wedge provides an integrated measure of the hemodynamic burden imposed on the pulmonary circulation by LA operating compliance and indirectly from LV operating compliance, whereas LVEDP only provides information about the LV operating compliance. The wedge reflects cumulative hemodynamic impacts of ventricular atrial coupling and its operating compliance on the pulmonary circulation, whereas LVEDP serves as a surrogate measure of LV preload and LV diastolic operating compliance. Because wedge reflects the hemodynamic burden on the pulmonary circulation from both the LA and LV operating compliance, wedge has a greater prognostic significance than the LVEDP. For these reasons, when you are trying to calculate pulmonary arterial resistance and evaluate dystonia exertion, you should try to measure the mean wedge when possible instead of relying just on the LVEDP. The differences between LVEDP and wedge become particularly noticeable when there is a large V wave that increases the calculated wedge. Large V waves of the wedge occur in mitral regurgitation, atrial fibrillation with poor LA operating compliance, and stiff LA syndrome. Other conditions that can cause the wedge to exceed LVEDP are mitral stenosis, pulmonary vein stenosis, and pulmonary veno-occlusive disease. To summarize, the situations where wedge exceeds LA pressure are pulmonary vaso-occlusive disease, i.e. CTEPH or pulmonary embolism, and pulmonary vein stenosis, for example, post-pulmonary vein isolation for atrial fibrillation. Situations when wedge exceeds LVEDP are mitral stenosis, mitral regurgitation, and atrial myxoma. Situations where wedge is less than LVEDP are non-compliant left ventricle and aortic insufficiency. That was a very detailed tour through all the findings you would expect to see on a routine pulmonary artery catheterization. I hope that is helpful to you.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.